When the macrophages attack the stem cells, what happens is macrophages break down the cell membrane. They extract the bioactive peptides, which is so powerful in the stem cells, is released in the body. And it is released all over the body. It is not localized because it is, as we saw in the first picture, it is very, very minute structures. 2 nano, less than nano. So it can spread all over the body. So the effect we are seeing from the treatment of the cases of the stem cells is the extract of the stem cells, which is prepared in vivo. This is an extract prepared in vivo. And as long as it is in vivo, this means that the body utilized and used all the active components of the cell organelles even. This is why when we give extract from the market today, it cannot make anything, because how they produce this extract. How they produce this extract? They just put the cells in hypotonic solution. Normally, cells swell, rupture. They take this rupture, either centrifuge it or filter it, and throw away the rest. What they take these elements. What they throw these elements. 80% of the contents of the bioactive peptides in our body is inside the cell organelles. So when they make extract today, they just make 20%, they give us 20% of the power of the cells they are using. Add to this, the processing make you lose another 5%. Storage and transportation logistic operations make you lose another 5%. So you get 10% of the value of the cell, which practically nothing. And this what made me, I want to run a bit, I know the time might be not enough. This what made me try to create or try to make inside my lab extract of the stem cells which contains all the bioactive peptides of the organelles. So my challenge was not to break the cells. Breaking the cells is very easy. Just put it in hypotonic solution. My challenge was breaking the cell organelles. And in the same time, I make this extract keep the value of the cell membrane, which is rich in phospholipids. Phospholipids are essential factor for regeneration of the cell membrane. Cell membrane gives integrity of the cell. The stronger the cell membrane, the much healthier the cell. And this is what I can claim and patented already. Its results as extract, I call it ACE-PICO extract. Why I call it PICO extract? Because the technique I used with the help of one of my friends, Chinese engineer, that we made the cells suffer from pressure equal 1000 barometer. So we cut the cells with a special technique into 0.25 micron, and we take these particles, make it suffer from pressure 1000 barometer under very cold conditions, which keep for us all the bioavailability of the bioactive peptides. And here is the result which came in. This is our curve in comparison to Heidelberg University curve. Heidelberg University, I followed the same technique but with my protocol. I followed the same amounts. And I compared their curve to my curve, and this is the result. And there was another one. This one was one of the American companies. This is a private company, a private American company, and this one is mine. What I want to say to you is, extracting the cell, keeping its bioactive peptides, this is, I am keeping the A plus B plus C plus MY plus MN plus XY. I'm keeping all the factors of the cell, not only for one hormone or one enzyme or one protein, for all the hormones of the cell. And we know each cell, according to the organ it is in, have different bioactive peptides, have different cycles of production. What about the administration route? Administration route, classically, they give IM or IV. Right? Okay. We have a common say in my culture. Say what? If you have a tied knob, why do you open it with your teeth as long as you can open it by your hand? Right? If the buccal mucosa can deliver to me 95% of the bioactive material, and if my particles are pico size, which means much, much smaller than the sublingual veins and the buccal mucosa, so it will be absorbed very easy from the buccal mucosa. Why do I need to make it in injection or parenteral? The second concept, does this work? Is what I'm saying now working? We come to the subject of today, the diabetes complications, diabetic nephropathy. I will not go through the details of each process of how the kidney is spoiled. I just remind you that according to all the guidelines, let us classify diabetic nephropathy. It starts by 5 years after the patient of diabetes not controlled, microalbuminuria. 5 years after this, gross proteinuria. 5 years after this, they start to decrease the EGFR, deteriorating within 10 years. So 20 years from the start of diabetes, the patient is sleeping beside the machine of the hemodialysis, right? By studying, we found out that what the lesion is sclerosis of the glomeruli. The glomeruli is sclerosed. There is explanation as the microvascular circulation. There is explanation as the direct effect of the glucose particle of the hyperglycemia. There is an explanation of the big molecules of the microalbumin which pass through the tubules and it makes physical scratches. But under any condition, at the end of the day we have degeneration and we have sclerotic glomeruli. The second problem of diabetes, diabetic retinopathy. The most accepted explanation for the mechanism or the pathogenesis of the diabetic retinopathy is the microvascular changes. The microvascular changes makes occlusion, partial or temporary, and sometimes permanent to some of the capillaries which supply the retina, leading to focal necrosis, leading to fibrosis. Can this be reversed? This was the first question which, before I start this project I asked myself this question, and the answer came to me from here, from Italy. There is a scientist called Marconi, 1995, 2005. He made a clinical trial trying to reverse the sclerosis of the glomeruli. So he followed Paul Meehan in giving extract, and he used stem cells, but he was a lot genius by adding ACE inhibitor, captopril, in very small dose, 12.5 milligram per day. Why? Because according to his studies, no matter what he will do or give to the kidney, as long as the intraglomerular pressure is high, it will never repair. So he gave the captopril just to decrease the intraglomerular pressure, to give chance for the other bioactive peptides to work and regenerate. And he succeeded. Me, in my approach, I don't like to say I like green environment and I'm anti that, anti this. No, I was just thinking, whatever our body can offer, why I should take it from outside? Do we have ACE inhibitor in our body? Do we? Something makes the same effect of ACE inhibitor to decrease to us the intraglomerular pressure? There is, and all of us know it. And we use it today as a marker for the heart failure. What is it? Atrial natriuretic peptide, ANP. We use the ANP today. ANP, this is a peptide, comes from the atria as a result of its stretch due to the heart failure. So with its increased level in the blood, we know the degree of heart failure in the patient. What is the effect, the pharmaceutical effect of ANP? Its pharmaceutical effect is to decrease the atrial pressure.
By antagonizing aldosterone.
And in the same effect, it does it for the glomeruli by decreasing the intraglomerular pressure. Improve perfusion, help for the heart failure. This is again another cause for which the atria release it in the blood when it starts to stretch. There is an overload. So I said to myself, why I don't mix the extract of the atria with the extract of the kidney. So now I will follow my Marconi and decrease the intraglomerular pressure. And I will offer to the kidney the ABCD MNXY. Will it work? My patients from Philippines, China, and Malaysia. I practice in the three countries. I told you the last 10 years was in these countries, so I have lots of patients there, and I know lots of diabetics there, and I know lots of diabetics with diabetic nephropathy. Some of them are waiting for transplant, and some of them are suffering from the story of the dialysis and every day going and coming. And again, it makes you pain as a clinician when you have nothing to do to the patient. We made this experiment on 40 patients. 40 patients, 3 of them had microalbuminuria. I did for the microalbuminuria because if it succeeds with the microalbuminuria, at least if it cannot help the big group, which is the diminished eGFR, at least I will be able to protect the kidney. So it can be prophylactic, not only treatment. So with 3 patients of microalbuminuria, confirmed by 6 times in between checking their urine, 3 patients of gross proteinuria, and 36 patients with eGFR ranging from 60 to 36. Stage 4, I didn't have luck to find, because stage 4, they are a bit far from reach. They are either on the way to transplant, so they are not ready to mess themselves up. But the one who is still not in the stage of transplantation want to do anything to go back. This why it was easier to try it with this.